All right. All right. Good afternoon, everybody. It is Tuesday, the 15th of December. It is also known as the Ides of December. You ever hear of the Ides of March? Yeah, it's a Shakespeare thing. But the Ides means the 15th. Yeah, a little unneeded information, but every 15th I call it the Ides. My wife is kind of tired of it, but it's all good. All right, so yesterday we hit all the bones. We got through them all. Today I'm going to try to hit as many muscles as I can. So I would definitely use the sheet that I sent out with the muscles that'll be on the practical. I'm not just going to go through the muscles that are on the practical. I'm going to hit all the muscles again that are going to be required not only on the practical but on the exam. So it's long, it's boring, but it is definitely necessary. So we'll start now. Let me pull up share the screen bit here. All right, what the heck is that? I don't want that. Let me change the screen to the full screen. Give me 1 sec. Here we go. Come on.
I see it.
I don't. There it is. Oh, what the heck happened? All right. I had it and then it went. Slideshow resume. Okay, let's try that. Okay. That was weird. All righty. So you guys have already received this also. So this is the muscle PowerPoint. And again, you'll be seeing this again probably the Thursday of week 1. The Monday of week 2, we have off for Martin Luther King Day. So you'll probably see it on Tuesday and Wednesday of week 2 also. All right. So again, the muscular system, muscles of the head, we don't have too many that we're going to be concerned with. Those are special. That's for specialty. Temporomandibular joint. The information that I'm going to give you on that joint and those muscles are quite specific, and it's really the information that'll be on the national exam. It's not that much. The muscles of the trunk, I mean, we do go over when we're talking about the rectus abdominis and the transverse abdominis, the internal and external obliques, very important muscles. The muscles that act on the shoulder and the upper limb, man, we do a lot of work on those muscles. And finally, the muscles acting on the hip and the lower limb. Now, this picture, this slide here is something I would look at, because what you guys want to do is, like the bones, I want you to get an idea of where all of these muscles are. All right. So again, if you look on top, there's a little key. So if you look at the picture on the left, there's a little blue key on top of his head that says superficial and deep. So the superficial muscles are really the ones on the left hand, well, on his right hand side, and the deeper ones are on his left hand side. And the same thing on the back on the picture to the right. You want to kind of get used to pictures like this because it gives you direction. It literally is a key, because if you know where the deltoid is, well, you kind of know where all the rotator cuff muscles are, because they're located deep to that area. So it's really important to understand where muscles are, all right, and what side of the body they are. Because when you know what side of the body they are and how they contract, and here's the thing, you'll learn a little bit about this in intro, but when you flex your elbow, the muscle contracts, the muscle shortens, okay? And that's an important aspect of muscle physiology. It's a little confusing. You think that it lengthens. Well, it doesn't. When you contract your elbow, all right, with your palms up, well, the biceps muscle contracts and you can feel it. If I just go like this with my palms up, I can feel the biceps muscle working. All right, what's interesting is if I go palms down and do the same thing, biceps aren't working anymore. Again, it's one of my magic tricks that I do enjoy telling people. And it's interesting stuff, but just the same movement, just by switching the hands, changes the muscle that's working. And that's what differentiates us as physical therapist assistants from everybody else. Our knowledge of the anatomy, all right? It's deep and it's tough stuff, but it's interesting. All right, so getting an understanding of where these muscles are. Again, when we're talking about the head muscles, I'm going to need you to know how the mouth moves. So I need you to know these words. Depression. Depression is when we depress the jaw and that opens the mouth. Elevation lifts the jaw, hence closes the mouth. We have protraction and retraction. We see that on the shoulder blade when we do the punching muscle, and we'll talk about that when we get the serratus anterior and the rhomboids and the middle trapezius. But protraction brings the jaw outwards, retraction brings the jaw inwards. Lateral and medial excursion is moving the jaw back and forth like this, and it's a grinding of the food. Now, the muscles underneath, you'll see there's 4 muscles. You're only going to need to know one of them. All right, when we get to it, we'll go over what you need to know. What I do need you to know is what nerve innervates these muscles. Cranial nerve number 5. It is the trigeminal nerve. To touch. I know that's my acronym for it. There's 12 of them, and it's a very nasty one. Maybe I'll tell you someday what it is. But there's a long story behind it for when I went to school, so it's quite interesting. It's interesting to me, but because it was funny as heck. But again, all 4 of these nerves of the face have something to do with the chewing, the elevation, and those movements. And they're innervated by the cranial nerve number 5. So that could be a question that I give on my quizzes. Most likely the muscle questions will start on probably the Tuesday of week number 2. So know the movements, know the trigeminal nerve, that cranial nerve number 5 innervates them all. All right, temporalis, we're not going to worry about. Masseter, no. Medial pterygoid, no. But this muscle, now remember, like I said, when you see a star next to it, when you see it, well, this muscle is not on your list. So I will not put this muscle on your practical, but it is definitely open game on all of my quizzes. All right, so anything with a star is open game on the quiz. All right, and we'll talk about the muscles that are on the practical. What you need to know about this, I'm not going to ask you its proximal attachment or its origin, but I need you to know its insertion. It inserts onto the articular disc of the temporomandibular joint, or the TMJ. All right, the lateral pterygoid is also a very important muscle to open the mouth. It's a very important muscle that does depression, the opening of the mouth. Okay, so the 2 things I need you to know: lateral pterygoid is connected to the articular disc, and that is something we'll talk about more in kinesiology. And its most important action is that it is the muscle that opens the mouth. And again, it is a cranial nerve number 5, all right, is that innervates it. Okay, so To touch. Did I say trigeminal nerve? I think I just forgot about it for a second there. Yes, trigeminal nerve. Woohoo! Okay, so lateral pterygoid, trigeminal nerve. All right, the hyoid muscles we won't be working on. All right, muscles of the neck. Also, you will hear this as the cervical area. Most of the muscles have an origin on the vertebral column, on the thoracic cage, and the pectoral girdle. And then they insert onto the cranium. Makes sense. In order to move the head, those muscles have got to be attached to the head. So the neck or head has multiple actions. Okay, it has multiple actions. When we bring the chin towards the chest, it's known as flexion, tipping the head forward. When we bring the head back, like we're going to look up at the stars, that is known as extension. Lateral flexion is tipping your head to one side. We can do it to the right. We can do it to the left. Lateral flexion, direction-wise, would be, I want you to bring your ear to your shoulder. Bring your ear to your shoulder. Lateral flexion is not bring your shoulder to your ear. Okay? That is scapular elevation, bringing your scapula upward. Rotation is basically turning your head to the left and turning your head to the right. Remember, we talked about, when we talked about the terminology, that you guys are going to need to know that movements, that muscles move on the same side. So if it's a right side muscle, it turns to the same side, the right side. Those are known as ipsilateral movements. And then we have muscles that move to the opposite side. So again, if it's a right-sided muscle, it makes some kind of movement to the left. That is known as a contralateral movement. So you need to know those words. Now, some of the muscles that you're going to need to know, the neck flexors, the sternocleidomastoid. All right, we spoke about that when we spoke about the sternum yesterday and the clavicle and the mastoid process. Again, the name of the muscle is telling you where it comes from and where it ends up. Okay, and that muscle you can call the SCM. The scalenes are three muscles. You're not going to need to know the scalenes, but I need you to understand it could be on your national. It's three muscles. They perform the same actions as the sternocleidomastoid. And we'll talk about the sternocleidomastoid because that is one of the muscles that will be on your practical. The neck extensors. So neck flexors should be up front, and they are on the front side. Neck extensors are on the back. So when they contract, it brings the head back. The trapezius, especially the upper trapezius, because isn't that the only trap that connects directly to the skull? Its origin is on the occiput, specifically on the external occipital protuberance. And I just want you to know that the two splenius muscles perform head extension. All right, I need you to know that. So the sternocleidomastoid is one of your muscles that you're going to need to know on your practical. I know it is not on your list. Please add it to your list. If it hasn't been added, add the SCM. Add it. Very important muscle, a muscle we work with an awful lot because it leads to torticollis in children. You're going to need to know everything about this muscle. You're going to need to know its origin. Now, here's the thing. Like I said, if you forget it, look at the name. Sternum, sterno, means it comes from the sternum. Cleido means clavicle. Mastoid means mastoid process. Look at the origin and insertion. Origin is a proximal attachment. Insertion is the distal attachment. the origin is the mastoid. Sorry, for SCM, it's backwards. All right. The manubrium is the origin, and the insertion point is the clavicle and the sternum. So it's a little backwards. So the origin is the manubrium. All right, that small bone on the temporal side, on the temporal bone. Its insertion or distal attachment is, I'm sorry, my apologies. I just got confused. My apologies. So the origin is the manubrium on the sternum down here and the clavicle. It inserts onto the mastoid process. Okay, so sternocleido is the origin, mastoid is the insertion. It's innervated by cranial nerve number 11. That is the accessory nerve. Sternocleidomastoid is very confusing as it pertains to actions. There are two. You have them right here on your each on your side here, and they are palpable. You can palpate them. When they work together, when the left and the right work together, they perform flexion of the neck. Remember, it's on the front. So when these muscles contract, it brings the head down. They have unilateral actions also. What happens is the sternocleidomastoid, when it contracts, when you do lateral flexion of the head, it's performed on the same side. So the right sternocleidomastoid does lateral flexion. And if you palpate the right side of your neck and bring your right ear to your right shoulder, you will feel those muscles contracting. So that's an ipsilateral muscle. All right. It performs ipsilateral lateral flexion to the same side. Here's the tricky one. Sternocleidomastoid does rotation to the opposite side or the contralateral side. So again, looking at the right sternocleidomastoid, it rotates the head to the left. It rotates the head to the opposite side. Again, if you feel it, you can feel it when you turn your head to the left. If you were to turn your head to the right, you would not feel it at all. The sternocleidomastoid bilaterally flexes the head. Ipsilaterally, laterally flexes the head. Contralaterally, it rotates the head. Now, the SCM is an important muscle, all right, in that when it is tight, and it's usually tight in children, the disease process is known as torticollis. And what happens with torticollis is that the child's head is so tight, it stays in all the positions of the movement. So if the right sternocleidomastoid is tight, the head will be in flexion, lateral flexion, and rotation. The child will look like this, all right? Literally with his head like this. It's up to us to stretch them and to also teach family members how to stretch the children, because we're not with the child all day long. Well, we teach moms and dads with children who have torticollis to stretch their babies every time they have a dirty diaper. Every time they have a dirty diaper, you take an extra 10 minutes after you clean them up and stretch their head. We stretch them in extension. We stretch them in lateral flexion to the opposite side and rotation to the same side. All stretching is the opposite of actions. That's all stretching is. So for sternocleidomastoid, you need to know everything about it. The scalenes This is what I need you to know about the scalenes. Number one, it's not on your practical. It could be on a quiz, but the only information I would give is the information that I'm telling you now. The scalenes are located on the first and second ribs. All right, they insert onto the ribs. They do the same actions as sternocleidomastoid. Bilateral flexion, ipsilateral lateral flexion, contralateral rotation. And I'm going to use those words more and more, so you got to get used to them. Okay? The scalenes are very important in the taking in of oxygen. All right, because the insertion is on the ribs. When the insertion comes closer to the origin, when they contract, it increases the size of the area of the lungs, allowing more oxygen to come in. So what I need you to know about scalenes, they attach to the ribs. They perform the same actions as sternocleidomastoid. There are 3 of these muscles, and they help with inspiration. They help with the taking in of oxygen. Splenius capitis, you'll see it has a star next to it. All I need you to know about splenius capitis and cervicis, you will notice that this muscle is on the back portion of our heads. If it's in the back, it's going to extend the head. That is the just. So if you see anything with splenius capitis and cervicis, it is head, neck, or cervical extension. It could be any of those. Remember that ligamentum nuchae is just a piece of ligament, a thick ligament, where muscles attach to. Basically, it adds surface area to the back. Those spinous processes are very thin. Well, they add when we were made, we were made well. The ligamentum nuchae adds surface area and allows for more muscles to attach to close to the vertebral column. The muscles of the trunk, all right, we have a few of them. Let me take a look on the list just to make sure which ones we have here. Geez, I don't see any. I don't see any of the muscles here. All righty. Okay. So we're going to go through them. They will be on my quizzes. So again, knowing where the muscles are located is important. So you'll see the superficial muscles, sternocleidomastoid. You can see upper trap there on the superficial, deltoid, pec major, the biceps brachii. Those are easily palpable, and you can feel them right now. But the deeper muscles that are underneath them, subclavius, under the clavicle, not a muscle we worry about. Subscapularis, which is on the anterior side, of the scapula. Pec minor, which is deep to pec major. Coracobrachialis, there's another muscle that just the name is telling you where it's coming from and where it goes to. Its origin is on the coracoid process, and it inserts onto the brachium, which is the humerus. So it only has one action, which is shoulder flexion. Serratus anterior starts on the first 9 ribs and comes around the scapula and attaches onto the medial border of the scapula. So understanding where these muscles are is very, very important. We need to breathe in order to live, all right? And it requires a few muscles to do it, all right? We do go over inspiration and expiration in kinesiology, where we talk about it a lot more. Know the names of these muscles: the diaphragm, which is the workhorse, the internal and external intercostals, the small muscles between the ribs. Those are very, very important in breathing. Terminology-wise, you need to know the medical terms. When we take in air, air intake is inspiration. All right, so the taking in of air, inspiration. The expelling of air, the getting rid of air is expiration. All right, so inspiration is we breathe in, expiration, we breathe out. We smell the flowers, we blow out the candles. Take in the oxygen through our nose, we blow it out through our mouth. You don't want to be a mouth breather. If you're a mouth breather, the oxygen does not go into the lungs, so it's not distributed correctly. If you see somebody that's a mouth breather, they're working very hard, but the oxygen is going into their esophagus and into their stomach. Not a good thing. So some of the other muscles that contribute to breathing, Sternocleidomastoid, Scalenes, Pec Major, Serratus anterior, Latissimus, and the abdominal muscles, internal and external oblique, intercostals, and the transverse abdominis. The most important or the primary muscle of inspiration is the diaphragm. All right, the diaphragm is not on your list for your practical, so it will not be on your practical. It will be on my exam in some way, shape, or form. On my quizzes, it will be. All right, the diaphragm comes from the xiphoid process, remember the end of the sternum, and the lumbar area. You need to know that. You need to know the nerve that innervates it. It is the phrenic nerve. You will see numbers next to them. In this case, C3 through C5. All right. Do not worry about that. You will not need to know that until we get into tests and measures. When you start dermatomes, because that's where the body is separated. All right. We'll talk about that in month number 5. And the main action of the diaphragm is inspiration, the taking in of oxygen. All right, so the diaphragm, when it contracts, pushes down, opening up this whole lung area, allowing for more oxygen to come in. Okay, so xiphoid process is its origin. It's innervated by the phrenic nerve. Its job is inspiration, taking in of air. The internal and external intercostals are not part of your practical. Will be something on my exam, though. I will not ask you where its origin or insertion are. Know that they are between the ribs. Intercostal. Costal means ribs. Inter means between. These are the muscles in between. Don't confuse these muscles with the internal and external obliques. Sometimes people get them confused. What you need to know about these muscles is what's in the colors in the action section. External intercostals help with inhalation. Remember, I said EI. External, inhalation. EI and IE. The internal intercostals helps with exhalation. EI, IE. External intercostals helps with inspiration, EI. The internal intercostals helps with exhalation or expiration, and that's IE. This is actually a question on one of your exams. I believe it's in kinesiology. It's on one of our pre-post tests. The diaphragm and the external intercostals work together, all right, in tidal volume. And that's something we'll get to when we get to kinesiology. So again, external intercostals in between the ribs helps with inhalation. Internal intercostals helps with exhalation. The rectus abdominis, I don't see this muscle on your list. Nope. And nope. I'm not going to add. I'm not going to add it to it. It will be on my quizzes. What I need you to know that I need you to know the origin and insertion. The origin is the pubic crest or the pubic symphysis. That's down in the lower hip, and it goes up to the xiphoid process. And I need you to know the action of this muscle is trunk flexion, allows you to come forward like that at the trunk. Now, in between, so you see there's two parts to this muscle, creating that 6/8 pack effect. Well, there's a white band or a sheath, and that sheath that connects these two muscles bands is known as the linea alba, and the linea alba is a place for attachment also. Remember I said on day 2 when we talked about muscles that the rectus abdominis, your quote unquote core muscles, are truly not a core muscle. Okay, I know I'm going to go work my core, and you're thinking that you're working your abdominal area. Well, you're really not. You're really not. All right, rectus abdominis is not a core muscle, but the next one is, and you'll learn about that in kinesiology also. The transverse abdominis, again, not on your practical, all right, but it will be on my quizzes. This is one of the core muscles, and that won't be on your quiz. But what I need you to know is that this is the deepest abdominal muscle. It is a corset muscle, all right? You will see this muscle as capital T, small case r, capital A. You'll see it as TRA. Okay, so transverse abdominis is below the rectus abdominis because you see it actually inserts on the linea alba, that white sheath tissue that connects the rectus abdominis muscles. The internal and external obliques, they are not on your practical, but I can promise you, I'm telling you that these two muscles will be on my quiz. All right. I will not ask you about its origin and insertion. I need you to know kind of the direction of these muscles first. The external oblique is like putting your hand in your pocket. It goes in this direction. So if you were to put your hand in your pocket, that's the direction of the external oblique. The internal oblique goes in the opposite direction. Internal oblique goes in the opposite direction. So external is like putting your hand in your pocket. Internal is opposite of that movement. Now, the important things that you need to know. In order for us as human beings to rotate our trunk, we need both of these muscles to work. We need them both to work at the same time, but they both move differently. And this is where the national exam gets you. So the internal oblique rotates the trunk to the ipsilateral side. What that means is that the left internal oblique rotates our trunk to the left. The external oblique rotates our trunk to the opposite side. It rotates our trunk to the contralateral side. So here's the scenario. I'm sitting here and there's a noise to my right. I'm sorry, to my left. I rotate my trunk to the left. The left internal oblique and the right external oblique work at the same time to rotate my trunk to the left. The left internal oblique rotates to the same side. The right external oblique rotates to the opposite side. So if you were to write this down, so put rotate to the left equals the left IO plus the right EO. And it's the opposite way. If we rotate to the right, thankfully, there's only two forms of rotation here. If we rotate to the right, it'll be the right internal oblique and the left external oblique that work together to rotate to the right. That's what you're going to need to know. All right, that's what you're going to need to know. On the national exam, can they do something where they put the origin and insertion down? Yeah, they can. But here's the thing. You know, internal and external obliques are in your abdominal area. So if you think of them kind of together, they have origin and insertions on the ribs and on the iliac crest, basically. That's what you need to know. I mean, I'm not going to ask you about origin insertion. I'm not going to ask you about innervation, but I will ask you about action. And we as PTAs are all about action. Okay, so internal obliques rotate our trunk to the ipsilateral side or the same side. External obliques rotate our trunks to the contralateral side or the opposite side. Very important to understand that concept. Really important. All right, now let's get to some muscles that we will be working on our practical. So the Pectoralis Major. All right. So if I showed this picture like this, it wouldn't show any of the names there. All right. If I showed this picture, well, this is definitely the pec major, no doubt about that. And you're going to have to tell me it's the pectoralis major. Its origin comes from the sternum and the clavicle. The sternum and the clavicle, it inserts into the bicipital groove. All right, it inserts into the bicipital groove. This is a medial and lateral pectoral nerve innervation, medial and lateral. The actions, you need to know them all. And again, just if you were to picture this muscle, I guess we're going to pull out the old pencil. So here's the origin right here, and its insertion is right here. Okay? When this muscle contracts, it shortens. The insertion comes closer to the origin. Remember, the insertion is here on the humerus bone. So it's going to bring the humerus inwards. So pectoralis major does a deduction of the shoulder. When this contracts, it shortens, brings the insertion closer to the origin. It actually rotates the humerus a little bit. It rotates it inwards. So it rotates it medially or internally. When this whole big muscle is working together, it is a shoulder flexor. There are 4 shoulder flexors. You can remember it by the acronym ABC in pec major. The A is the anterior deltoid. The B is the biceps brachii. The C is the coracobrachialis, plus the pectoralis major. So right now we got a deduction, internal medial rotation, flexion of the shoulder. It also does something known as horizontal adduction. If you were to bring your arm, abduct it, and flex your elbow, you'd be in this position, like on a horizontal plane. Adduction means to move it inward. So we would bring our elbow in like this. This is adduction. When we bring it away, it's abduction horizontally. It's on the horizontal or transverse plane. So that is the fourth major action of pec major. So its actions: shoulder adduction, shoulder flexion, shoulder internal or medial rotation, and shoulder horizontal adduction. And again, you can see it from this picture. It sits in the bicipital groove right here. All right, its insertion sits right here. All right, it's only going to move the shoulder. It's going to do nothing here at the elbow. Here's the elbow down here. Pectoralis major has nothing to do with the elbow, has everything to do with the shoulder. So you should never tell me anything about the elbow when we're talking about pectoralis major. Pectoralis minor is another muscle that we will have on the practical. Pectoralis minor is located deep to pec major. All right, so basically this picture has pec major taken off. I need you to know its origin and insertion. Ribs 3, 4, and 5. They come from ribs 3, 4, and 5. All right, right here. This is the origin, and it inserts right here onto the coracoid process. All right, onto the coracoid process. Just like pec major, it's the lateral and medial pectoral nerve. This muscle protracts the scapula, brings the scapula forward. All right. It also does scapular depression, bringing it down. It works with another set of muscles as a force couple. We'll talk about those in kinesiology. What you need to know now is that it does scapular depression and scapular protraction. Pec minor and serratus anterior are the two muscles that perform scapular protraction. That's the bringing of the arm forward, the bringing of the scapula forward. Well, there's two muscles that does retraction of the scapula. Remember, those muscles are the rhomboids and the middle trapezius. Just by their location, it'll tell you that it brings the muscles back. So pectoralis minor, another muscle that is going to be on your practical. It might help if I get rid of my artistry here. Okay. All right, some posterior muscles of the trunk. So these are muscles located on the back of the trunk. The levator scapula. Let me see here. Unfortunately, I don't see it on the list. The levator scapula is not on your practical, but this is an important muscle of the upper back. You'll notice its origin is on the transverse processes of C1 through C4, really C2, C3, C4. And it inserts into the superior angle and the medial border between the superior angle and the spine of the scapula. Its main action is to elevate the scapula. Again, you guys have to start to think in 3D. All right. So here's right down here is the insertion. It inserts into the scapula. Its origin is up here. Remember I said when a muscle contracts, the insertion comes closer to the origin. Well, if the insertion is coming closer to the origin, it's going to make the muscle go in that direction of the arrow. Well, it's connected to the scapula right here. Well, the scapula is going to go in that direction too. Hence, Levator scapula, look at the name, levator, goes up. Elevation, levator scapula, elevates the scapula. We will teach you about the other action that it does in month number 2. The trapezius muscle, this is a key muscle in everything that we do. All right, this muscle is on, got to be there. Where's trapezius? There it is. Okay. Right under latissimus. Trapezius, on the practical, it'll be a picture of it. It'll look something like this, where the muscle comes this way, the muscle comes this way. So it'll look something like this. All right. It'll look like a highway. So if you look at this one, the muscle goes here, comes here and down. It goes here and goes here and down. So it kind of looks like my picture up there. That's how it's going to look on the practical. And when you see that, you'll say trapezius, and we'll go to the next muscle. When we're talking about this muscle on my quizzes, it's a whole different world. You've got to know the 3 parts to this muscle and each of their origins, insertions, and actions. Up here is the upper trap. This area right here is the middle trap, and this area down here is the lower trap. Let's look at each. The upper trap has its origin on the occiput bone at the external occipital protuberance. It inserts into the lateral third of the clavicle. The middle trap has its origin from C7 to T5 on the vertebra, and it inserts onto the acromion process. The lower trap goes from T6, remember middle trap stopped at T5, it goes from T6 to T12. The trapezius has nothing to do with the lumbar area. Nothing to do with the lumbar area. So the lower trap goes from T6 to T12, and it inserts into the spine of the scapula. So you need to know the origin and insertion of each of the 3 parts of the trapezius. The whole trapezius is innervated by the accessory nerve. That's cranial nerve number 11. You need to know the actions. The upper trap elevates the scapula. Take a look at where it is. Take a look at where it is. All right. When it contracts, it lifts the clavicle, hence it lifts the scapula. The middle trap, remember I said the middle trap does retraction. All right, retraction. Protraction is the bringing forward. Retraction is the bringing back. All right, so middle trap and serratus anterior. Middle trap and middle deltoid are your 2. Now, what am I saying here? Middle trap and the rhomboids, sorry about that, are your retractors. All right. Pectoralis minor and serratus anterior are your protractors. The lower trapezius depresses the scapula or brings the scapular down. And just for your own information, the lower trap is actually the largest of the 3 trapezius muscles. So trapezius will definitely be on the practical and on your competency. And on your quizzes. The rhomboids is another muscle that is going to be on your practical. Remember I said, for us, you're not going to have to know it as a rhomboids minor and a rhomboids major. Think of them as one unit. So on the bottom here, I wrote the origin and insertion as 1. all right, as one. So the origin goes from C7 to T5, the spinous process. So that's this area right here. So here's the origin, and it inserts right here on the medial border of the scapula, right here. So you see this rhomboidal, square-shaped muscle right there. So C7 to T5, spinous process to the medial border of the scapula. The rhomboids are innervated by the dorsal scapular nerve. Its main actions, like I said, is retraction of the scapula with the middle trapezius, but it also helps with elevation of the scapula and with a downward rotation of the scapula, which we'll work on when we get to kinesiology. So the two actions that I need you to know will be scapular retraction and scapular elevation. The latissimus dorsi, a major muscle, an expansive muscle. This is a muscle that will definitely be on your practical and will definitely be on your quizzes. Remember, this muscle has many, many origins. The vertebral spine, the sacrum, the iliac crest, the lower four ribs, and the inferior angle of the scapula. So it's that inferior angle that is forgotten most, okay? It's a big muscle. So iliac crest, vertebra, the sacrum, bottom four ribs, and the inferior angle. That's the origin of latissimus dorsi. It inserts onto the floor of the bicipital groove. So remember, we spoke about another muscle earlier, the Pectoralis Major, which also is in that bicipital groove. All right, also. So you're going to see a couple of the same motions between latissimus and pec major. But you got one muscle, the pec major, on the anterior side, and you got latissimus dorsi on the posterior side. So remember, so pec major did flexion of the shoulder. Well, latissimus is on the back. It does extension of the shoulder. Because it's in the bicipital groove on the anterior side, it adducts and medially rotates the shoulder, just like pec major, right? And it also, because it's on the inferior angle of the scapula, it brings down the scapula. It does scapular depression. So latissimus dorsi and Pectoralis Major have a lot in common. They have a lot in common, all right, action-wise, all right? They have opposite action between shoulder flexion and extension, and that's because you got one muscle on the front and one muscle on the back. Pec Major does shoulder flexion, and latissimus dorsi does shoulder extension. It makes sense. But because they insert into the same place, into the bicipital groove or the intertubercular groove, well, latissimus dorsi also does medial rotation and adduction of the shoulder. And because it has a origin on the inferior angle, it helps with depression of the scapula. The latissimus dorsi, you need to know that the nerve that innervates it is the thoracodorsal nerve, the thoracodorsal nerve. All right, so we have some of the muscles on the back here that we'll be talking about a little bit, and so a lot of these muscles we won't be worried about. Multifidi is not on your practical, nor will it be on my exams. I want you to know that this is a muscle on the back that spans multiple vertebrae. it might go from C3 to C5, and then from C5 to C7. And what the job of this muscle is to extend the vertebral column. It helps with extension. The Quadratus Lumborum is not a muscle, is it? No. Okay, Quadratus Lumborum is not a muscle that's going to be on your practical. The Quadratus Lumborum, though, is a very important muscle. This muscle right here, right? Its origin is on the iliac crest. So it starts low and it inserts into the lower ribs and the lumbar vertebra. I need you to know that, and I need you to know the actions. It does lumbar extension. It helps to laterally flex the trunk. Okay, those are the two important actions. But the most important thing about Quadratus Lumborum is that it is known as the hip hiker muscle. It elevates one side of the pelvis. Remember, I said that when you walk, our pelvis moves. Our pelvis goes to the right, goes to the left, to the right, to the left. Well, we have one muscle, the gluteus medius, that when the muscle, like a gluteus medius on the left side, is weak, well, the right pelvis drops. Something we call the Trendelenburg gait. We'll talk about that in kinesiology. It just drops. So that's why you see people when they walk, they'll advance their left leg and their right hip will drop. They advance their right, they left leg and drop. So they look boom, boom. Right? So they kind of look lopsided, when we should be even. Well, what happens is we try to compensate for those motions. Don't worry about this. This won't be on any kind of exam in intro. It will be on my kines exams. But what we do to compensate for that, because we have a weak muscle, is we'll lean towards the weak muscle area, or we will hip hike using the Quadratus Lumborum on the opposite side. So this picture right here, you're seeing a right Quadratus Lumborum. Well, if this hip drops this way, so if the left hip drops, well, the right Quadratus Lumborum will hike the hip up to even it out. So the Quadratus Lumborum is the body's hip hiker. It comes from the iliac crest and goes to the lower ribs. It lifts or hikes the hip up. It elevates one side of the pelvis. A very important muscle that does very, very important work. So here's just a picture to kind of give you an idea of what muscles are doing what. So in the middle, we have a neutral position. This model is standing straight up. You'll see, oops, sorry. Trying to get my pencil, my apologies. So you'll see muscles here on the back side. So here's the muscles on the back side, and you'll see muscles on the front side. So if we are in extension of our back and we need to get back to this, so we've extended the back. Well, it's not the extensors that need to work. It's the flexors that bring us back. So the rectus abdominis muscle, which does flexion of the trunk. The psoas major, also known as the iliopsoas, helps with bringing us back to this position. If we're flexed over, it's our back muscles that contract. So multifidus, semispinalis. And on the bottom here, the gluteus maximus gets us back to this straight up and down position. So if we're flexed, our extensors work. If we're extended, our flexors work. That's what this PowerPoint is basically showing you. When we laterally flex, all right, that's letter D here. All right, so here we're laterally flexing to the right. So here you could see these two parts are coming together and these two parts are coming further apart. So here is lateral flexion to the right. Lateral flexion to the right. Okay. So as you can see, in order to flex to the right, it's these muscles on the left-hand side that actually work to do that. Let's remember the rotation. All right. In this case, the rotation is going to the left. Well, here's the left internal oblique, and here's the right external oblique that's doing that action. Remember, we talked about that. So rotation, very important, very tricky. All right, the national exam loves to pick on that, and they love to get you guys with that. Don't let them. Don't let them get you with that. All right, so we have muscles at the shoulder. All right, okay. So we got anterior, we have different compartments of muscles. So let's go through some of them. The muscles that act on the shoulder, well, most of them start on the axial skeleton and they insert on the clavicle and the scapula because those are the areas that help with movement of the shoulder. The scapula is known as a false joint because it's not actually a joint with the thoracic cage, not like a joint between the femur and the tibia, or the glenohumeral joint between the glenoid fossa and the head of the humerus. The clavicle, which is between the sternum and the acromion process of the scapula, helps brace the shoulder. It's known as a strut bone. Again, it is the most fractured bone because it is so thin and flimsy. But it's very important in that the clavicle basically attaches the pectoral girdle to the axial skeleton. So here's some of the muscles we've already gone over. Right here is the big pec major. Here's pec minor. Subclavius, we will not be doing anything about, is under the clavicle. Sub means below the and clavius means clavicle. What else? So manubrium, sternum. Again, this is the large pec major right there. Now, we have a lot of movements at the scapula. We have a lot of movement at the scapula. The scapula needs to move in order for us to move so much in our shoulder area. So there has to be a medial and there has to be a lateral rotation. There has to be an elevate. There has to be a medial rotation. All right, this first picture right here shows that type of rotation. So we got a rotation going in this way, which is the medial rotation, where levator scapula, remember that muscle that comes up here, attaches here. The rhomboids, which attach all over here, all right, they work together to move it in this direction. And then we have a lateral rotation, bringing it in this direction. Well, that's the trapezius, the upper trap, and the serratus anterior that do that. The scapula also moves in an elevation and depression. So that's this picture here. It elevates, bringing the scapula upwards, and brings the scapula downwards in depression. Remember, we spoke about retraction and protraction. The scapula sits on the thoracic cage. Protraction is the bringing forward of the scapula. Retraction is the bringing back. Protraction is done by the pec minor and the serratus anterior. Retraction is done by the middle trapezius and the rhomboids. So protraction and retraction. All right, so we've gone through some of these muscles already, the trapezius, the levator, and the rhomboids. We've already hit them all. Here's some of the posterior scapular muscles. We're going to hit a lot of them now. The muscles that are acting on the arm, basically there's 9 of them. We've already gone over pec major and latissimus dorsi, and we spoke about how they definitely kind of do a lot of the same things. When you see pictures like this, what it's showing is the parts of the bone where the muscles attach to. The origin is in the pink. So you'll see right here. So this is a picture of the posterior scapula. So here's the spine of the scapula right here. It splits up the supraspinous fossa and the infraspinous fossa. Well, the 2 muscles in pink that sit here is the supraspinatus on top and the infraspinatus. All right, you see here along the sides, levator scapula is here, and the rhomboids are here. We talked about that. Okay. We talked Latissimus dorsi has that origin on the inferior angle. So whenever you see a bone like this, and when you come onto campus, we do have bones and models that look like this. That's what it's telling you, is that that section of the bone has a muscle on, has the muscle on it, and it's either an origin or an insertion. Same thing. This is the anterior side. So the other one was a posterior, and this one's the anterior side. We spoke about the rotator cuff muscles. These are 4 very important muscles that we must know, that you have to know. Here's the thing. If I was to walk down the hall and go, Ashley, what's the supraspinatus? You can't just go, I don't know. You're not teaching me that now. Not a good answer. But you can, and you'll tell me, all right, supraspinatus, its origin is on the supraspinous fossa. It inserts into the greater tubercle. It's innervated by the suprascapular nerve, and its action is shoulder abduction, and it does the first 30 degrees. That's what you got to tell me. And you got to tell me that for all 4 of these muscles. All right, all 4 of them. Good afternoon, John Carlos. We've been starting at 1 o'clock. I sent a message out. I've got things to do. So I'm doing these at 1 o'clock. Hopefully you're getting the videos and all will be good in the world. So today we're doing the muscles, as many muscles as I could hit today. And we'll try to finish them up tomorrow. So the rotator cuff muscles are known as the sits muscles. And that is made up of the first letter of the 4 muscles. You must know them. Supraspinatus, infraspinatus, teres minor, subscapularis. Those are the 4 rotator cuff muscles. They're called a rotator cuff because the 4 tendons cross over the shoulder joint, over the glenohumeral joint, and keeps the head of the humerus in the glenoid cavity. That is the job of the rotator cuff, to hold the humeral head in the glenoid cavity, because there is a muscle on top of it known as the deltoid that's trying to pull it out. This guy's trying to pull it out. These guys keep it in. It's a perpetual fight. All right. When those rotator cuff muscles get weak, the deltoid usually wins them over and starts to pull the humeral head out. That's known as a distraction, right? And you'll hear other words that it's called. The supraspinatus is the most injured because the supraspinatus actually goes underneath the acromion process. And sometimes the supraspinatus can make contact with the acromion process, which is a bone, and it causes something known as an impingement. And I can actually impinge you guys right now. I don't know if we did this, but what I want you to do is with your thumb up, I want you to bring your arm out to the side, and I want you to abduct your shoulder with your thumb up. And you go you go high. You go to about 180 degrees with your thumb up. Now what I want you to do is go thumb down and do the same thing. By moving your thumb down, you don't go as high. What happens is by just changing that position, the supraspinatus muscle is now making contact with the acromion process. It cannot go up any higher than this. If it goes up higher, you will tear your supraspinatus. Not fun. Trust me, I know. I tore my labrum and part of my rotator cuff on my left side, trying to hold a patient up to keep her from falling. That was about 10 years ago. So those things happen. The patient never knew that I had to go for surgery. Excuse me. So the rotator cuff muscles, those are stories you'll get when you hear. All right. On the anterior side, this is a kind of a tricky picture. On the anterior side of the body, there's really only one rotator cuff muscle, and that's the subscapularis. Where's my pencil? Subscapularis is on the anterior side. These three muscles are on the posterior side. Again, they have the anterior here and the posterior here, so it's kind of tricky. So these three, the sit is the posterior muscles, the subscapularis is on the anterior side. Right here, this whole muscle right here is subscapularis. Right? These muscles right here and this side is your rotator cuff, the supraspinatus, infraspinatus, and teres minor. So don't get too confused about this picture. All right, if you have any questions about it, you'll give me a yell. All right. So let's hit these muscles. All right, supraspinatus is on your list of muscles that will be on the practical. You need to know everything about supraspinatus. Its origin is from the supraspinous fossa. It inserts into the greater tubercle of the humerus. It's innervated by the suprascapular nerve, all right, above the scapula. And its action is shoulder abduction, specifically the first 30 degrees. Please notice the picture. Here's the acromion process right here. Here's the muscle going underneath and attaching onto the greater tubercle. If that muscle hits this acromion process, we've got a problem. That's why the supraspinatus is the most injured rotator cuff muscle. It's always in danger of being impinged. Okay, so we need to do things to keep it from being impinged. Second muscle of the rotator cuff is the infraspinatus, another muscle that you will need to know for your practical. Infraspinatus comes from the infraspinous fossa, below the spine of the scapula. It too inserts into the greater tubercle. It too is innervated by the suprascapular nerve. But infraspinatus is an external or lateral rotator of the humerus. It brings the shoulder outwards. Brings the shoulder outwards like that. Boom. That is the infraspinatus muscle. We're going to go through the teres minor here. We'll come back to the teres. So we're going to do minor right here. We'll do major after we finish subscapularis. Teres minor, again, another muscle that will be on your practical. Its origin is the teres minor is on this side here. All right, so teres minor is on this side. Okay, so its origin is on the border of on the lateral border of the scapula, and this muscle also inserts into the greater tubercle. So that is three muscles that attach into the greater tubercle: supraspinatus, infraspinatus, teres minor. They actually go literally in order. Teres minor, though, is innervated by the axillary nerve. Teres minor also does lateral rotation, just like infraspinatus. It also does adduction of the humerus. So after you abduct, teres minor helps bring the arm back, just like pec major, and just like latissimus dorsi. Okay, so that's the teres minor muscle. Teres minor. The fourth rotator cuff muscle is the subscapularis, below the scapula. Subscapularis is on the anterior side of the scapula. Subscapularis is another muscle that you will be responsible for on your practical. Its origin, it comes from the subscapular fossa of the scapula. That's on the anterior side. It inserts into the lesser tubercle of the humerus. The lesser tubercle. So the first three insert into the greater tubercle. Subscapularis inserts into the lesser tubercle. Subscapularis has an innervation of the upper and lower subscapular nerve. Subscapular job is to internally or medially rotate the shoulder. Take a look at how this muscle is. Here's the insertion point right here. Here's the origin. Remember I said the insertion, when we contract, comes closer to the origin. Hence, it rotates the humerus internally. It does this motion, bringing the shoulder inwards or medially. So those are the four rotator cuff muscles that you will be responsible for: supraspinatus, infraspinatus, teres minor, and subscapularis. Teres major, let me get my pen here. Teres major is this muscle right here. You'll notice that teres major is below teres minor, but they're both on the lateral border. Teres major is closer to the inferior angle. Remember, I spoke of another muscle that's on the inferior angle. That was the latissimus dorsi. Well, latissimus dorsi actually sits down here. Let me get my pencil. So latissimus dorsi sits here. They actually call the teres major a mini latissimus muscle. Right down here in this area is teres major, and you'll notice that other than shoulder extension, teres major and latissimus dorsi do the same things. Teres major inserts onto the lesser tubercle. Remember, we just spoke of subscapularis inserting onto the lesser tubercle. So you'll notice how this muscle goes to the anterior side of the muscle, of the bone. Its actions, because it's on the anterior portion of the bone, it medially or internally rotates. It helps with adduction of the humerus, and it also helps with extending the humerus. So teres major is a major muscle, but it is not a rotator cuff muscle. I repeat, teres major is not a rotator cuff muscle. The four rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. Those are your four rotator cuff muscles. The deltoid. Deltoid is a big, strong muscle, largest in the shoulder area. This muscle also you will be responsible for. Teres major. Teres major, you're also responsible for, by the way. The deltoid, as you can see, it's kind of a diamond-like muscle. Just like the trapezius, you're going to need to know trapezius is 3 parts. Well, deltoid has 3 parts also. The deltoid has an anterior part right here. It has a medial part right here, and it has a posterior part right here. They all insert into the deltoid tuberosity. So which means all 3 of these muscles have different origins. The anterior deltoid is on the lateral third of the clavicle. The middle deltoid is on the acromion process, and the posterior deltoid is on the spine of the scapula. Let's remember back to trapezius. The insertion of the upper trapezius is the lateral third of the clavicle. The insertion of the middle trapezius is the acromion process. And the insertion of the lower trapezius is the spine of the scapula. Again, there are ways that you can correlate and bring together the information that if you kind of forget something, remember, we got lots and lots of muscles, and you guys need to know a lot of muscles and a lot of actions. Anytime you can correlate them together with another group of muscles, it's going to be a plus. It really is going to be a plus. So anterior, middle, and posterior. They each have different origins, but they have the same insertion at the deltoid tuberosity. The deltoid is innervated by the axillary nerve. The axillary nerve. Each of these sections of the deltoid perform different actions. The anterior deltoid does shoulder flexion. Remember I said A, B, C, and pec major. So now we've got the A and the pec major. Anterior delt. The next ones will be biceps brachii and coracobrachialis. So anterior delt does shoulder flexion and shoulder horizontal adduction, bringing the shoulder inwards. The middle delt does shoulder abduction, bringing the arm out to the side. Remember, the rotator cuff muscle that does the first 30 degrees of shoulder abduction is the supraspinatus muscle. The posterior delt does shoulder extension. So does the lats. So does the triceps. Posterior delta does horizontal abduction, bringing it on the horizontal plane, bringing it away from the body. So the deltoid muscle, a very important muscle that we work on a lot. Very important muscle. The serratus anterior. Serratus anterior is a tricky muscle. This is a muscle you will be responsible for before. on your practical. Definitely responsible for it. You've got to know the important parts of this muscle. The origin is ribs 1 through 9. Serratus means rough cut. Think of a serratus cut. Take a look at the way these muscles are located on the ribs here. They look kind of like a serratus blade, don't they? Well, that's what makes it the serratus anterior. The reason it's anterior is because it actually goes in the front, of the scapula and comes around. I'll make this, comes around and attaches onto the medial border of the scapula. Onto the medial border of the scapula. So ribs 1 through 9 inserts onto the medial border of the scapula. Its main action that I need you to know is protraction, the bringing of the scapula forward, bringing of the scapula forward. Remember that the pectoralis minor is a protractor. So the main two protractors is serratus anterior and pectoralis minor. When this muscle gets weak, well, the scapula drops or it wings outwards. We'll talk about that in kinesiology. You have to know the innervation of this muscle. The national exam loves to pick on the innervation of the serratus anterior. So the acronym that I made up for it, I like salt. I like salt on my foods. I didn't get chubby for no reason at all. I like to eat. Well, salt, serratus anterior, long thoracic nerve. I have never forgotten it in 22 years. Never. Once I got that acronym down, it stayed with me forever. SALT, serratus anterior is the long thoracic nerve. Again, make up your own. Make up your own acronyms. It will work for you. The triceps brachii, another muscle that you are responsible for. Triceps means 3. Remember, biceps means 2. We haven't gotten to biceps yet. The triceps brachii, what I need you to know is where, first of all, where its long head has its origin. The long head of the triceps comes from the infraglenoid tubercle on the scapula. It's a bony prominence under the glenoid cavity. Infra meaning below, glenoid meaning the glenoid fossa. Tubercle means bone, a bony projection. Both the lateral and medial heads are on the humerus. I'm not going to drive you crazy about that. You need to know the long head is on the infraglenoid tubercle. It inserts onto the olecranon process down here of the ulnar. So here's the long muscle. It crosses the shoulder and it crosses the elbow. This is a 2-joint muscle, which means it's going to have actions at the shoulder and at the elbow. It's innervated by the radial nerve, and the 2 actions, thankfully, it's the same movement, just at different joints. The triceps at the shoulder does extension, just like Latissimus Dorsi, just like teres major, right? Triceps does shoulder extension, and it does elbow extension. The triceps and the anconeus work together to do elbow extension. So triceps brachii, axillary nerve innervation, does shoulder and elbow extension. Its origin, the long head is on the infraglenoid tubercle, and the medial and lateral heads are on the humerus, and it inserts onto the olecranon process of the ulna, on the point of your elbow, right there, bam, triceps. The biceps, another muscle that you are responsible for on your practical. Biceps meaning two. All right. So you're going to need to know this muscle a lot. Cold. You need to know this muscle. So the two origins of this muscle. First origin is up here. The long head of the biceps origin is the supraglenoid tubercle of the scapula. Remember, the triceps long head is the infraglenoid tubercle. So above the glenoid is the long head of the bicep origin. Below the glenoid is the tricep origin. Nice and tricky for you. Nice and tricky. I understand. The other muscle tendon that makes it a biceps, the short head, comes from the coracoid process. We spoke about the coracoid process. That's that finger projection. And actually, the pectoralis minor attaches there from ribs 3, 4, and 5. All right, we're going to find out another muscle that comes from there in a few minutes. So this muscle crosses the shoulder. It crosses the elbow. And it crosses the forearm. This muscle is greater than a two-joint muscle, which means it's going to have 3 different movements at 3 different joints. Okay? Its insertion is on the radial tuberosity. The radial tuberosity, very important. It's innervated by the musculocutaneous nerve. The actions are is what is important. At the shoulder, it does shoulder flexion. So now we have 3 out of the 4 muscles that perform shoulder flexion. Anterior delt, biceps brachii, plus pec major. So there's one more, there's C, and that'll be coming up in a second. At the elbow, it does elbow flexion. And at the forearm, it does supination. So the actions are shoulder flexion, elbow flexion, and supination. If you want to stretch the biceps out, you do the exact opposite. You extend the shoulder, you extend the elbow, and you pronate the forearm. Bring it behind you. You will feel a very nice stretch in your biceps. That's how you stretch anything. You do the opposite of its motion. So the biceps brachii, long head, comes from the supraglenoid tubercle. The short head goes from the coracoid process. The long head goes through the bicipital groove. Remember, there's a lot of muscles that go there. The pec major, latissimus dorsi. And now the long head of the biceps come through there. It inserts into the radial tuberosity. Remember, I said for pronation and supination of the forearm, the only bone that moves is the radius bone of the forearm. So it makes sense that the biceps brachii, which does supination of the forearm, has to be on the radius. So if you forget, you've got to say, okay, well, there's only one bone that moves, and that's the radius bone. So it's got to be sitting there. So the musculocutaneous nerve is the innervation. 3 major actions: shoulder flexion, elbow flexion, supination of the forearm. A muscle we work on every single day. Brachialis. So remember, I spoke about the brachium being the humerus. Well, brachialis comes from the humerus, comes from the distal end of the humerus, and it attaches onto the ulna, attaches on the ulna. So the only job of brachialis, because it only crosses the elbow joint. Take a look at it. As you can see here, here's the elbow joint right there. It has nothing to do with the shoulder. Brachialis's only job is to perform elbow flexion. This is the second muscle that performs elbow flexion. Remember, I said a second ago, the biceps brachii does elbow flexion. So does the brachialis. And brachialis is the workhorse. It's the favorite of the nervous system because we want to save energy. We don't want all the elbow flexors to work. We're going to talk about another one in a few minutes. We don't want them all to work at the same time. We want to save our energy. So brachialis is the usual one that's picked. Now, if you got to screw a screwdriver, screw a screw into the wall or something, and you got to perform supination with elbow flexion, well, it makes sense that we'd use the biceps because brachialis has nothing to do with supination, and it can't. Why? Because it's not on the radius bone. It's on the ulna. Remember, I said the radius creates the movement. The four muscles that work on pronation and supination all are on the radius bone. Brachialis has the same innervation as the biceps. It's the musculocutaneous nerve, and its only job is to flex the elbow. And yes, you are responsible for this muscle in your competencies and your practical, sorry. Get rid of my picture. Why is it not working? Okay, now you're being a pain in the tuchie. All right. All right, why isn't it working? All right, let me go to the next one. See if I can get it off in this way. Nothing is clearing. Great. There it is. Okay. All right. Fantastic. All right. The next muscle is brachioradialis. The name is telling you where its origin is and where its insertion is. Well, its origin is on the brachium, on the humerus. Radialis means that it's on the radius bone somewhere. We just don't know where yet. That just looking at the name, it's telling you. Okay, the origin is on the lateral supracondylar ridge of the humerus. Remember, it's that bony ridge above the lateral epicondyle of the humerus. It inserts into the styloid process of the radius. Now, it's said that this muscle does a little bit of pronation and supination, but it's not a main mover. And the reason it's said that way because it's on the radius bone. But the main movement of brachioradialis is elbow flexion, elbow flexion. So we have three main movers of elbow flexion, and brachioradialis is also on your list. So the three main movers of elbow flexion, biceps brachii, brachialis, and brachioradialis. BBB equals elbow flexion. And again, it's very important to understand how these muscles work. With the forearms supinated and we flex our elbow, you will feel the biceps work. You will feel them work. If you put your hand in the neutral position and do elbow flexion, you will not feel the biceps work too much. This position is the brachioradialis working? Let me show you how you know. Flex your elbow and put your hand under the table and push your hand against the table. You will see a muscle pop out on the top of your forearm. That is the brachioradialis muscle right there. The third elbow flexor is brachialis. You can do brachialis by doing palm down and doing elbow flexion. Remember, this muscle starts on the humerus and ends on the ulnar. Again, feel your biceps. You can't feel it working. It does not contract. Maybe a little bit, but not a lot. Not like if you turned your palm upwards. Feel the biceps pump now. All right. A couple of tricks that you can talk to your family about. So elbow flexors is BBB. Elbow flexors are BBB. The anconeus, not a muscle that you're going to need to know on your practical. On the quizzes, though, I'm going to need you to know what the job of the anconeus muscle is. The anconeus muscle works with the triceps to extend the elbow. Small muscle that works to do elbow extension. That's what I need you to know about anconeus. Coracobrachialis. Here, again, the name is telling you about this muscle. You know nothing about it right now, but the name, coracobrachialis. Coraco means it's coming from the coracoid process. Brachialis means it's going to the brachium or the humerus. Okay, so let's take a look at the picture now. All right, coracobrachialis. Well, here's the origin right here. Here's its insertion on the humerus. It crosses only the shoulder joint, which means its only action is at the shoulder. Only action at the shoulder. Has nothing to do with the elbow. So the fourth shoulder flexor is the coracobrachialis. The best way to know it is, let me think, coracobrachialis isn't on my list here. Incredible. Wow, I don't have coracobrachialis on the list. What was I saying? Oh, coracobrachialis is the fourth shoulder flexor. So the mnemonic for that is ABC plus pec major. Anterior deltoid is the A. Biceps brachii is the B. Coracobrachialis is the C. And pec major is the pec major. Okay? Comes from the coracoid process, inserts into the humerus. Just like the biceps, it's a musculocutaneous nerve innervation. And its only job is to flex the shoulder. Only job is to do shoulder flexion. As you can see, though, if you were to abduct your arm, it would lengthen. It would stretch out. So that when you brought the arm back into adduction, the muscle would contract. So it's thought of as a weak adductor of the shoulder also. It's not a main mover. It's not like pec major or like Latissimus Dorsi. Those are major adductors of the shoulder. Now the forearm muscles, there are many of them, and you're going to need to know most of them. All right. So we've already gone over these muscles, the ones that act on the forearm. Right. We've gone over most of these. We're going to hit the pronator and the supinator. All right. So let's talk about the pronators and supinators a little bit. Supination And these motions occur at the forearm. This is a joint between the radius and the ulna. It does not happen at the wrist. The wrist goes for the ride. The wrist goes for the ride. This is a forearm motion. Forearm motion. Pronation and supination. So the supinator muscle, the name tells you what its action is. It does supination. All right. You'll see that it ends up on the radius bone. It comes from the medial epicondyle and goes to the mid-radius bone. It helps to supinate the forearm. The biceps brachii also does supination of the forearm. And supination is where the palms face anteriorly. Supinator is not one of the muscles. Okay. Pronation occurs by two muscles, the pronator teres and the pronator quadratus. The pronator teres comes from the lateral border of the humerus and inserts onto the radius, while the pronator quadratus, quad meaning four-sided, looks like a square, has its origin on the distal ulna and inserts into the distal radius. So let's go look at them. So the supinator muscle, all right, this muscle does supination of the forearm. It comes from the lateral epicondyle and inserts onto the radius. Its job is to perform supination of the forearm. Now, a lot of flashcards and will say that you might get a little bit of elbow flexion here, but not much. All right. The supinator is the muscle that's used first, like brachialis is the workhorse for elbow flexion. The supinator is used most when we need supination. Now, if we have something like we need supination and elbow flexion, well, that's when the biceps would come into play. The pronator teres. Pronator teres comes from the medial epicondyle. It inserts into the radius. It performs pronation of the forearm. It too can be thought of as a weak elbow flexor, but it's weak. It's not a main mover. It's not like the BBB. But if we lost the BBB, the biceps, the brachialis, and the brachioradialis, pronator teres could function as a weak elbow flexor. The pronator quadratus is this muscle that's on the distal side right here. You see it down here. Again, quad meaning four. It's a square muscle. Its origin is on the ulna, the distal ulna. Its insertion is on the distal radius. It does forearm pronation. Boom, done. So you'll notice pronator quadratus is more on the distal end, coming from the medial epicondyle to the radius. Pronator quadratus is on the distal end, going from the ulna to the radius. And again, if it's a supinator muscle or a pronator muscle, its insertion is always going to be on the radius. That's the only way it can happen. The only way it can happen. All righty. All right, some of the forearm muscles. All right. I'd like to try to get through a few more, and then we'll end it today and finish up the lower extremity tomorrow, and kind of go over day one tomorrow. So flexor carpi radialis. Again, let's just look at the name. So it's going to be a flexor of some kind. Radialis means it's going to be on the radial side. So when I say radial side, I'm talking about the thumb side. of the forearm. Carpi means wrist. So anytime you see carpi, this muscle does nothing at the fingers. It only has an action at the wrist, either wrist flexion, which is what it is, it's a flexor, or radial or ulnar deviation. Does nothing at the fingers. Okay? Its origin, when you're talking about flexors of the forearm, the medial epicondyle is known as the common flexor tendon. You will find a great deal of muscles that are flexors that are on the medial epicondyle. This is a muscle that you will need to know for your competency. So what you're looking for here is where its origin and insertion is. Well, it's at the medial epicondyle, and it goes all the way to the second metacarpal, right here, the second metacarpal. Okay, it has nothing to do with the fingers. All right, so the two actions that this does is wrist flexion and radial deviation. Wrist flexion, radial deviation, deviates to the radial side. And by the way, radial deviation is also known as wrist abduction. Well, it darn looks like I'm bringing the thumb inwards. Well, if I'm in anatomic position though, and I do radial deviation, I'm bringing the wrist outwards to the lateral side. Remember, we base all our movements off of the anatomic position. This is a tricky muscle. This muscle is not part of the carpal tunnel. All right, this muscle is not part of the carpal tunnel, and you will need to know that when we're talking about the carpal tunnel. Flexor carpi ulnaris, another muscle you will need to know for your competency. Again, if you break it down, it's a flexor, which means it's going to be, its origin is going to be near the medial epicondyle. Ulnaris, well, okay, the muscle's probably going to end up near the ulnar side, near the pinky side. That makes sense. It's a carpi, which means it has nothing to do with the fingers, which means it only has something to do with the wrist. Flexor carpi ulnaris, again, starts up here. Here's the medial epicondyle. Here it goes down and goes to the fifth metacarpal. The fifth metacarpal also attaches to the pisiform. Remember I said that there is a bone on the wrist that is a sesamoid bone. Well, the pisiform carpal bone is the sesamoid bone because it is within the flexor carpi ulnaris tendon. Okay? The pisiform is embedded into the tendon of the flexor carpi ulnaris, sesamoid bone. The action of flexor carpi ulnaris, wrist flexion, because it crosses the wrist, and ulnar deviation, deviation that goes to the ulnar side. So the name is going to help you guys a lot. You just got to, don't freeze when you're taking tests. Don't freeze. A lot of people freeze and they forget these things. All right, so there's an actual order to this. All right, so if you were to go from the medial epicondyle, putting your pinky on the lateral side, you'd see that it goes ulnaris, palmaris longus, carpi radialis, and pronator teres. Just a little bit of information there. Speaking of palmaris longus is a flexor. If it's a flexor, it's most likely coming from the medial epicondyle. This is not a muscle you will be responsible for because not everybody has one of these. It goes from the medial epicondyle, ends up in the palm. All right, something known as the palmar aponeurosis. It's a thick tissue. The only job of palmaris longus is to flex the wrist. It does nothing with a deviation. And remember, approximately 10% of the population does not have one. All right. Again, I have a palmaris longus. If you guys just bring your thumb and your pinky together and flex your wrist a little bit, you will see a tendon that pops out. Well, on my left side, I've got palmaris longus. On the right side, I don't. I know, very interesting, very cool thing. Now we go to the extensors. Extensor carpi ulnaris. This will be one of the muscles you'll need to know. Extensor carpi ulnaris. Again, let's break it down. Flexors come from the medial epicondyle. Extensors come from the lateral epicondyle. So the origin of this extensor is the lateral epicondyle. Well, we can move it together now. Carpi means wrist, which means there'll be no extension at the fingers by this muscle. And it's on an ulnaris, which means it's on the ulnar side. It's on the pinky side. Let's see if that's true. The origin, lateral epicondyle of the humerus. It inserts into the base of the fifth metacarpal. Remember, we're talking about the back here of the forearm. This is the extensors. And the action is wrist extension and ulnar deviation. Makes sense. Makes sense. Extensor carpi radialis longus and brevis. You will be responsible for extensor carpi radialis longus on the practical and both on my quizzes. It's an extensor, so it's most likely going to come from the lateral epicondyle. Brevis does come from the lateral epicondyle. Longus is a little longer, is actually above it a little bit on the supracondylar ridge, but it also has a piece of the lateral epicondyle. Longus inserts into the second metacarpal. Brevis inserts into the third metacarpal. So we have one muscle goes to the second metacarpal right here. And then the brevis goes to the third metacarpal. Okay. So longus second metacarpal, brevis third metacarpal. They both do the same action. They extend the wrist and they radially deviate the wrist. Again, if it's on the radial side, it's going to be it's going to perform some kind of motion with deviation. All right, so that's those muscles. Now we're going to look at some muscles that affect the fingers, okay, that affect the fingers. Flexor digitorum profundus. If it was up to me, this would be on your practical. It is not, unfortunately. Profundus and superficialis are very important, and you must know them. And it will be on my quizzes. Flexor, so it's going to be close to the medial epicondyle. In this case, it's the proximal ulnar. It's pretty close, but not close enough. The flexor digitorum profundus is very special. It inserts into the base of the distal phalange. Profundus flexes all the joints of the fingers. This joint, the PIP, and the DIP. Profundus does wrist flexion and flexes the MCP, the PIP, and the DIP. Very important. Profundus flexes the DIP. Superficialis does not. Superficialis does not. Superficialis, the flexor, it's coming from the medial epicondyle. Digitorum means digits. Superficialis. Superficialis only goes to the PIP, which means it can do this, but it cannot flex the DIP. All right? It goes to the side of the middle phalanges. So it can flex the PIP, but cannot flex the DIP. So you'll notice on the bottom of these, I have them highlighted. All right. Profundus flexes all the joints of the fingers, MCP, PIP, and DIP. Superficialis does not flex the DIP. It only flexes the MCP and PIP. And don't forget, because it crosses the wrist, it does wrist flexion also. Flexor pollicis longus. When you hear the word pollicis, you're thinking thumb. Pollicis means thumb. Flexion of the thumb is the crossing over like that of the thumb. Crossing over of the thumb. Okay? So flexor pollicis longus. It's not a muscle you'll need to know for your practical. It does flexion of the thumb and it does wrist flexion also. Extensor digitorum is a muscle you will need to know for your practical. By the way, that's all of the upper extremity muscles right there that we've gone over on the practical. That's good. The origin, again, when we're talking about extensor, should be the lateral epicondyle, and it is. Digitorum means they're going to the digits. They go to the base of the digits. So it does wrist extension and it does finger extension. Extensor digitorum. Extensor indices. So these next few muscles are, you're not responsible on your practical, but they will be on your exam. Extensor means it's going to be an extensor movement. Indices means the index finger, number 2. Okay, so it inserts into the index finger. It does wrist extension and extension of the index finger. Extensor digiti minimi. It's an extensor, so it's going to extend the wrist. Digiti minimi extends digit number 5. Small digit, pinky. It extends the finger and extends the wrist. All right, carpal tunnel. I will need you to know that for the exam, for your exams. Carpal tunnel syndrome is prolonged repetitive motions of the wrist. All right, it causes the tissues to get inflamed, really, really swollen. And what happens is there's a tunnel right here. All right, there's a piece of tissue that covers the tunnel, and the base of the tunnel is the carpal bones of the wrist. There are many structures that go through there. The flexors and the median nerve are some of them. If there's pressure on that median nerve, if you were to press down on this area, your fingers would actually give, as you can see, mine kind of are, and you would feel a little bit of a shocky feeling. All right. What happens with carpal tunnel is that so much pressure is put on the median nerve, it causes tingling and numbness in the palm, on the medial side of the hand, right in this area, and it rotates and it comes up to the shoulder and to the arm. Now, the usual treatment, we use, the patient will use anti-inflammatories to get the swelling down. We might do some very gentle exercises. We might immobilize the wrist to keep it from moving, so those motions don't occur all the time. But what happens a lot of the time with carpal tunnel syndrome is that we can't get it any better. So what happens is a doctor will go in, perform surgery, will cut out a piece of that retinaculum so that no pressure is put on the median nerve. So when we're talking about carpal tunnel syndrome, we're talking about a median nerve injury, a median nerve injury. That's what it looks like. All right, that's the tunnel itself. Here's the flexor retinaculum, that piece of tissue. In the yellow here is the median nerve. All right, it's coming through here. And as you can see, if you press on it, it's going to hurt like the dickens. But there's a lot of flexor muscles that go through there. So watch, again, if I push down on my fingers, I push down on that carpal tunnel, my wrist will flex and my fingers will give, all right, because I'm putting pressure on those flexor muscles. All right, so carpal tunnel syndrome, you'll learn about it in pathophysiology. All right, the intrinsics of the hands, I just want you to take a quick look at them. Opponens digiti minimi, this does opposition. The pinky moves towards the thumb. You're not going to need to know these, nor will I test you on these. Opponens pollicis, where it does, the thumb does opposition. So when you got opponens digiti minimi and opponens pollicis working together, it performs this opposition movement. Abductor pollicis brevis, this muscle helps perform abduction of the thumb, where the thumb comes towards you. That's abduction. Bringing it back is adduction. Flexion is across the thumb, across the palm. Extension is back. Flexor pollicis brevis, another flexor of the thumb, crossing the thumb like that. Abductor digiti minimi, it's an abductor muscle. So it's a muscle that, I'm sorry, abductor digiti minimi. So it's abducting or bringing the small pinky finger out to the side. All right. When we abduct the fingers, we abduct and adduct. And everything is based off of the third digit. I'm not going to stick it up for you like this, but the third digit. All right. Everything is based off the third digit. Abductor digiti minimi abducts the pinky. Flexor digiti minimi brevis flexes the pinky. The palmar and dorsal interossei we'll talk about in kinesiology. Okay, we're up to the lower extremity. All right, we're I'll stop the share. All right, so tomorrow I will go through the lower extremity muscles. Hopefully that shouldn't take more than about an hour and a half. And then the last half hour, I'll probably go over what day one is going to look like. Again, during the vacation, well, during the next 3 weeks, we are on vacation, actually. I will be checking my email throughout the day. It won't be every 2 hours like I do now, because I am going to go away with my wife somewhere. We just haven't decided yet where we're going to go.
I do have a weird question. Do you know when are we gonna have like a 3-week break sometime spaced out that's not Christmas for us? Like, is it gonna be a summertime? Because I know my family wants to do a vacation, and obviously I won't do it if I can't.
We have the Christmas vacation is usually 3 weeks. You guys are going to start in January, so January, February, March, April, then May, June, July, August. Then you'll have September and mid-October. September to mid-October. Then you'll have a 2-week class in October. Then all of November and all of December. Now, That puts you at next Christmas. You'll have a 3-week vacation then. But here's the thing. The national exam is given in January, second Tuesday in January. If you want to take it then, I wouldn't go on vacation.
No, but is there going to be like a 3-week vacation?
No, there's a week, January, February, March, April. There's a week at the end of April. May, June, July, August. There's a week at the end of August.
Okay, awesome. Okay, that's good to know though.
Okay, so,
All right, thank you.
and then you have the regular holidays.
Yeah.
So,
when do clinicals run into? Don't they run until November or?
January, February, March, April, May, June, July, August. So your first clinicals will be in September. The first clinical will run 6 weeks. Then that'll get you to mid-October. And then you come back to class for 2 weeks for therapeutic exercise 2. When you finish that class, you then go out on an 8-week clinical. So November and December, an 8-week clinical that usually ends like our group ends at the end of this week. All right, our group that's out now ends at the end this week, and then they can take the national exam in January, or they can wait till April. So your clinicals will be from September through December.
Okay, awesome.
Okay. All right. Any questions, concerns?
No, thank you. See you tomorrow.
All right. Next to last video. So we'll see you guys tomorrow.